Hello and welcome to another episode of the ABIP podcast. This is your host, Abhinav Agarwal from the Zucker School of Medicine at Hofstra Northwell in New York. The views expressed on this podcast are those of the speaker alone and not necessarily those endorsed by the ABIP. So for today's episode, we are very excited to welcome Dr. Matt Inra from New York. Dr. Inra is an assistant professor of cardiovascular and thoracic surgery at the Lenox Hill Hospital at Northwell Health. In this very interesting two-part episode, we will cover some basics of thoracic surgery for pulmonologists and interventional pulmonologists, as well as provide a thoracic surgeon's perspective in the management of lung cancer, as well as pleural diseases. So Matt, welcome to the ABIP podcast. We are so excited to have you here.
Thank you so much for having me. I'm very excited to be here.
Perfect. So, before we dive into part one, where we discuss more about lung cancer management, do you have any conflicts of interest for the purpose of this episode?
I have no conflicts of interest to disclose.
So, Matt, I've always been fascinated. When I first came to the United States, I came across the robotic VAT surgery, and, coming from somewhere where we didn't have the robotic surgery, it always fascinated me as to a traditional VAT versus a robotic VAT. And as I've continued my journey, through pulmonary medicine, I've seen a practice pattern where there are some thoracic surgeons who do a regular VAT, and then there are some thoracic surgeons who do a robotic VAT. So what is the difference in between the two of them?
It's a great question. And robotic assisted surgery has really become more popular recently. The practice has changed a bit amongst thoracic surgeons, and the a number of operations being performed through a robotic assisted approach has been increasing. In years before that, the transition from an open thoracotomy to a thoracoscopic approach similarly increased. Basically, thoracoscopic surgery is minimally invasive surgery for the chest. That stands for video assisted thoracic surgery, meaning we use cameras and smaller instruments and smaller incisions to perform operations in the chest that would normally be done historically with a posterolateral thoracotomy or a big incision. The benefits of that surgery is that we don't use rib spreaders, which cause a lot of postoperative pain. And we decrease the amount of incisions and the size of the incisions that we use. So we don't cut through the latissimus and the serratus, which can cause a significant amount of postoperative pain for patients. When you do traditional VAT surgery, the camera that you use is a 10 millimeter, 0 degree or 30 degree camera, which allows you to see around the chest and see around the pleural cavity. But the instruments you use are straight stick instruments. They do not have a wristed joint at the end. So your degrees of freedom and your range of motion with these instruments to perform your procedure is limited. Robotic assisted VAT surgery. So basically it's a thoracoscopic operation and a minimally invasive operation, but the tool is different. The tool is the robot. The robot has 4 arms. 1 is used for the camera and 3 is used for surgical instruments, whether it's a retractor or a dissector or a grasper. And these instruments have 8 degrees of freedom in their range of motion. So basically, they act as one's own hand with a wrist, and you have all the degrees of freedom of your own hand and your own wrist. So the benefit of robotic surgery is that you are almost performing open surgery with your hands and wrists with small incisions and less pain and less trauma to the patient.
That is fascinating, the advent of robotic surgery, and some of it is slipping into our field of pulmonary and interventional pulmonary itself. So do you feel like it is more comfortable, as somebody who does robotic surgery, do you feel that it makes a difference? And in that accord, is there data out there that the outcomes are actually better with robotic VATs, or we are still in the early phases where we don't really know if it makes a difference in terms of, patient outcomes or complications when compared to the traditional video-assisted thoracoscopy surgery?
Yeah, I'll answer the first part of your question first. And in terms of my own preference, I think the robotic assisted platform is exceptional. And compared to traditional thoracoscopic surgery, personally, just anecdotally, I think it is better. I think it's more comfortable for the surgeon. I think it allows the surgeon to see better and actually perform a better dissection. And in terms of cancer, that translates into lymphadenectomy. It translates into dissection of the lymphatic tissue along the pulmonary artery, and it translates into better parenchymal margins, or achieving better parenchymal margins. And to answer your second question, in terms of data, is one proven to be better than the other? Unfortunately, there are no prospective trials out there comparing VATS and robotic assisted, traditional VATS and robotic assisted surgery. But in all the retrospective trials, they have shown that they are basically equivalent in terms of outcomes. Some have shown that lymph node dissection is better with robotic surgery. Some have shown that length of stay is better with robotic surgery. Some have shown that morbidity is better with robotic surgery. The cost is higher with robotic surgery, but the length of stay in the hospital is sometimes shorter. So, there are no clear conclusions that can be made with the retrospective studies that are out right now, but it would be interesting to see what, prospective studies would show comparing the two techniques.
I agree. And I think, that is unfortunately hard to do, but something that will, I think, guide a lot of future research in terms of is one better versus the other. And of course, we can't forget the satisfaction of the operator and the ease of the operator. As we find out again in our field of pulmonary medicine, it's easier for us to do robotic assisted procedures. And I'm sure that translates into the same for a thoracic surgeon as well. So jumping a little bit, in terms of lung cancer, you mentioned both lymphadenectomy or, lung resection. So I always faced with that question, especially when I was training and as a pulmonologist, when you see a nodule that looks to be a peripheral nodule, abutting the pleura, close to the pleura, it is small in size, we are not concerned about, mediastinal involvement or hilar involvement. How do you decide between, when the patient comes to see you and when you're talking to them, a wedge resection versus a segmentectomy versus a lobectomy? Can you shed more light on this for our listeners?
Yeah, great question. I think just as the technique and approach for lung cancer is changing over time, I think the extent of resection, especially recently, conversations have been had about what is going to be the new standard of care for a small peripherally located lung nodule. Traditionally from the lung cancer study group and Ginsburg, the gold standard of care for lung cancer treatment in resectable lung cancer has been a anatomic lobectomy with a mediastinal lymph node dissection. Outcomes in terms of survival were equivalent, but compared to sublobar resection, the risk of local recurrence was lower with a lobectomy. So throughout my entire training and for, since the 90s, the gold standard was lobectomy. With some of the new studies out right now, like the JCOG 0802 trial and Dr. Al-Torki from Cornell's CALGB trial, the question is the new standard of care for peripherally located small lung nodules less than 2 centimeters is the new standard of care segmentectomy. And it's a very interesting question because recently I think people have tried to spare parenchyma of the lung when doing a lung resection. When I think about peripheral nodules, I think about the patient and I also think about the nodule. Is the nodule solid? Is it spiculated? Is the SUV especially high? Or is it a ground glass nodule that's 1 centimeter and not very hot on PET scan? I think the latter, I think those are good options for doing a sublobar resection. When I think about the patient, I think about their functional status. I think about whether they have a single nodule or multifocal lung cancer. And I think about their pulmonary function. And that really helps me determine who might be a candidate for a sublobar resection and who might be a candidate for a lobectomy.
So do you think in terms of, sublobar resection, it is a more technically challenging procedure, and that is why, it's taken longer to adopt this kind of a surgery? Or do you think that people are still worried about, the rate of recurrence postoperatively, and therefore it's going to take more studies to, move towards a sublobar resection and a more lung sparing approach?
I think it's probably a little bit of both, honestly. I think one, segmentectomy is more challenging than a lobectomy, and that goes back to thoracoscopic versus robotic assisted. With robotic assisted surgery, it is less difficult, but it is still a more complex, more technically involved operation. So, one, I think that may help make a decision for a surgeon. And I think, I just personally speaking, I think dogma, and I think training, and I think, I guess you can call it tradition, may affect a decision to perform a lobectomy versus sublobar resection. I think for patients who are great candidates for surgery, who have excellent lung function, who are on the younger side, who have a peripheral, maybe 1 to 2 centimeter solid nodule, I think I would still talk to them about a lobectomy until things are really really clear in terms of local recurrence and overall survival and disease-free survival.
Right. So, we need more long-term data that there is no recurrence in the latter period and these patients are followed longer. That makes sense. So exactly. Then, sometimes I've seen patients, with really peripheral lesion, they'll just get a wedge. So, do you always have to do a completion lobectomy if your frozen is positive, or, based upon lung function, are there times when you consider that, a wedge to be with curative intent?
Yeah, I think in that situation, it's patient dependent, and obviously surgeon dependent, and they've weighed all the tumor factors and patient factors to decide that a wedge resection is the resection of choice. When you do a wedge resection for a lung nodule, the size to margin ratio should be 1-to-1 at least. So if you have a 1 centimeter lesion, you should have 1 centimeter margins at least. And when I think about a wedge resection, I think about patients who cannot tolerate either a segmentectomy or a lobectomy. Those are the patients who I'd perform a wedge resection on. Additionally, maybe if it's a redo chest, or if it's multifocal lung cancer, I would perform a wedge resection. But I think the key thing about performing a wedge resection is that the surgeon needs to perform a good lymph node dissection. With ground glass opacities, there's some debate about, the risk of lymph node metastases. But I think in order to appropriately intraoperatively stage the patient, I think, your hilar lymph nodes and your mediastinal lymph nodes should be dissected or sampled, and you should get a good lymph node dissection if you're performing a wedge resection.
And if you're trying to get away with a wedge resection, especially based upon the pulmonary function status, does that change the approach in terms of adjuvant therapy? Or if you really got the 1-to-1 margins, then you still would follow them, clinically and radiographically?
Good question. In the NCCN guidelines, they talk about worrisome features for indications for adjuvant therapy. And previously, wedge resection was considered a worrisome feature and a consideration for adjuvant therapy. I think if you're performing a wedge resection on a patient, or at least for me personally, that patient is probably a bit more frail probably has a bit lower functional status, probably has worse lung function than other patients. So in terms of consideration of adjuvant therapy, I think that's a discussion to be had between the surgeon, the patient, and the medical oncologist to see what the best option is for that patient.
Right. So you bring these patients to tumor board, discuss them, risk benefit, tolerance, functional status, and then make a joint decision. That makes sense.
Correct.
So switching gears a little bit in terms of mediastinal staging. So you talked about, mediastinal lymph node dissection. And, as a pulmonologist, I always think, the surgeon can get to all of the lymph nodes and they can, biopsy most of the areas. So tell me your perspective. Can you always get to, all of the lymph node, the hilar lymph nodes? What is a hard lymph node to get, as a thoracic surgeon? And on that account, when as a interventional pulmonologist, we do preoperative EBA, especially for, patients with a central tumor or, a larger than 3 centimeter tumor based upon the guidelines. Is it helpful for you to know if the patient has even as low as N1 disease? Does that change your surgical plan? Does that change your management approach?
So in terms of lymph node staging intraoperatively, first talking about the right chest, and then we'll talk about the left chest. Based on ACS Commission on Cancer recommendations, during a lung resection, 3 N2 stations must be sampled and 1 N1 station must be sampled for any lung resection that's considered curative for cancer. So, that being said, whenever I do a right-sided operation, I look for station 9 lymph nodes in the inferior pulmonary ligament, which usually are there. Sometimes they are not. I look for station 8 lymph nodes, which are periesophageal. And then I look in the subcarinal space for station 7 lymph nodes. And then I'll look in the paratracheal region for station 2 and sometimes, for station 4 and sometimes station 2 lymph nodes. So, pretty routinely, those lymph nodes and those stations are easy to sample or dissect and get to from the right chest. And in terms of hilar lymph nodes, usually there are station 10 lymph nodes around the hilum, around the superior pulmonary vein and sitting between the superior and inferior pulmonary vein. Additionally, you can find a station 10 lymph node around the origin of the truncus branch of the pulmonary artery. And then once you are doing your dissection, usually in the fissure around the other branches of the pulmonary artery to the other lobes, you can find station 11 and sometimes station 12 lymph nodes. So in terms of being able to appropriately stage and dissect out certain stations on the right side, I'd say it's fairly routine that you can sample multiple stations from the right chest. Alternatively, from the left chest, these lymph node stations that we can sample or dissect are a bit different from the right. Because of the location of the aortic arch, we cannot get to the paratracheal space, so we can't get to station 4 or station 2, but we can get to station 5 and 6 in the aortopulmonary window. So those are lymph nodes that we look for from the left side. We also look for station 7 in the subcarinal space again, and we look for station 8 and 9 in the inferior pulmonary ligament and periesophageally. And just like on the right side, we can find those 10, 11, and 12 lymph nodes from the same spaces around the hilum and along the pulmonary artery and near the branches. And I'm sorry, Abhi, can you remind me of your second question?
So, what I was asking was when we do EBUSs, there is some debate on should N1 lymph nodes be routinely sampled. And from a patient who has either, clinical N0 disease or there is no obvious involvement of N1 lymph nodes, does finding out that the patient may have N1 lymph nodes that are positive change your surgical plan or alter your surgical plan?
Yeah. I think those patients with N1 lymph nodes, as you mentioned, tumor board before, I think those patients are very important to present at your multidisciplinary tumor board because of, new developments in neoadjuvant treatment of lung cancer. Recently, the Checkmate 816 trial was published, looking at the role of neoadjuvant chemotherapy and nivolumab for stage 1B to 3A lung cancer resectable. So, neoadjuvant treatment for these patients with N1 disease is now an option and a pretty good option for some patients. And again, that decision would be made in tumor board and with the patient to discuss whether or not they want a neoadjuvant treatment. Otherwise, with N1 lymph node positivity, normally upfront surgery is offered. I think the most important thing, though, is on a PET scan, if you have positive hilar lymph nodes that are avid, it's important to perform the EVUS to rule out N2 disease. I think that's the most important thing with that positive N1 lymph node on a PET scan.
Right, because the surgical plan will change in terms of either neoadjuvant or not being a surgical candidate, depending upon those N2, multi-station or single station or even N3 disease. So I think that highlights the importance of performing in patients who have a high suspicion or one of these, features that are discussed in the ACCP guidelines where we perform a preoperative EBUS. I absolutely agree with that. So how often do you use something like a dye marking, either CT guided or bronchoscopic guided in terms of helping with your surgical approach? And is there a role routinely, or what kind of lesions are you looking for in terms of dye marking itself?
Yeah, great question. In training with thoracoscopic surgery, we marked nodules all the time, and we used technetium 99 for, it's a radio tracer, and we used a gamma probe in the operating room to mark the lesions, find the lesions, and resect the lesions. Nowadays with robotic bronchoscopy, you can use intraparenchymal marking such as ICG, and even sometimes fiducial markers are placed, and those can be used to help localize a lesion. In terms of frequency of using it, I've used intraoperative marking only a handful of times in the past, 2.5 years, because normally, in my own experience, the lesions have been solid, peripheral, and they are palpable in the operating room, where they are, we can find them grossly in the operating room. And I think that really determines whether or not I will pursue preoperative marking. If the nodule is a ground glass opacity on the preoperative CT scan, I think it's important to mark those lesions, because those lesions can be very hard to palpate in the operating room. And unless you're going to do an anatomic resection of that segment, I think doing a wedge resection would be difficult, because that lesion would be hard to find. So I think those lesions are very amenable to dye marking or pre-surgical marking of any type. And I think it'd be very helpful for resection for those lesions.
Just staying on the topic, one last question is, we always talk with my colleagues as to, when we are trying to biopsy the lesion, we have to be absolutely accurate. But when it comes to dye marking, how accurate do you have to be? Because there is some issues with when you're injecting the dye, there may be some spillage. So how accurate or close to the lesion, especially for something like a ground glass lesion, do you have to be to, appropriately and help you during the procedure, rather than just have a procedure that didn't really help you?
Yeah, I think when you're marking a lesion, I think the best place to mark it would be central from the visceral pleura. So if the lesion is 1 centimeter from the visceral pleura, I think placing your mark either 1 centimeter or further from the visceral pleura is the most helpful. Because if you know that the mark is behind the lesion, then the surgeon knows if they get the mark, the lesion is within that sample of lung. So I think when you're going to mark lesions, I think it is more important to mark central to the lesion rather than marking the lesion exactly, if that makes sense.
Yeah, right. So you want to get the borders, and that way you will make sure that you get the lesion and still have some leeway. in terms of getting, and so then you do a frozen and then go for the margins, I'm presuming, just from the surgical perspective?
Correct. If it's, if it's benign, you're done. If it's a non-small cell lung cancer, you can proceed to definitive resection.
That makes sense.
And obviously, if it's a secondary cancer, then gross margins are all that are needed.
Thank you. That's fascinating, and I've learned a lot about the thoracic surgery perspective. And we talk all the time, so this has been great. So this concludes the first part of our two-part episode. Thank you, Matt, again for taking our time, and I look forward to having you back for the second episode where we're going to actually discuss your perspective and a thoracic surgery perspective on the management of pleural diseases, which again, compared to lung cancer surgery, there tends to be more overlap in terms of the practice patterns between pulmonary medicine and thoracic surgery. So I look forward to that. And again, thank you for taking our time for today's episode.
Abhi, thanks so much for having me. This was great. I hope it was helpful, and I look forward to the second part as well.